Welcome to AETCM. Today we're discussing about an elderly female who came to ER with complaints of 2 days history of left upper limb and lower limb weakness. Should we begin, sir?
Yes.
So, a 72-year-old female was brought to ER with complaints of acute onset of left upper limb and lower limb weakness 2 days back. It was an acute onset, along with some slurring of speech, and also the bystanders noticed deviation of angle of mouth to the right side. Initially, actually, that day they couldn't go to the hospital. The next day, they went to a nearby hospital, and then they took an MRI and then referred the patient to here outside for further management. So, on arrival, the patient was conscious oriented, obeying to my commands. I went to the primary survey. She had a patent airway. There was no signs of any obstruction or anything. Breathing part, he had a respiratory rate of 16 per minute, and saturation was 98% in room air. Chest was clear. There was no signs of any no crabs and wheeze. Nothing was there. Circulatory part, heart rate was 80 per minute, and blood pressure was 140/70. GCS, she had a
What are the respiratory problems of a stroke? How do respiration become altered in a stroke?
One thing is actually if you're getting an acute like wheeze or cups or anything, you could suspect like aspiration.
So most common is always aspiration.
Then again, in worsening sensor in the patient may have like progressive like respiratory failure. There will be like slowing.
Low GCS can induce respiratory failure. Okay.
And then these the respiratory centers are predominantly in the midbrain
Okay.
and the pons
Medulla.
area, so medulla pons area. So if at all the patient has an infarct in the respiratory centers, the
Okay.
patient
So
cannot-
that is a third reason. Then any other neurological problem affects lungs?
Then
dystrophy, muscular.
That is a chronic
Long-term.
problem. Acutely anything can produce a problem in the lungs. That she told already. That is a respiratory center that is affected. Then you can have diaphragmatic weakness. Then neurogenic pulmonary edema. Okay, raised ICP or thoracic trauma or like that. Thoracic trauma or both both stroke and thoracic trauma can produce neurogenic pulmonary edema. Okay. These are the common causes for respiratory distress, but here the most common cause is aspiration because of low GCS.
So on disability part, she had a full score of GCS. People so equally reactive, but she had noticeable left hemiparesis. So we quickly went up with the primary survey. Exposure part, she was febrile, and GRBS check was 121 milligram per deciliter. As part of the primary urgent, we took an ECG also. It was not showing only sinus rhythm at 68 beats per minute.
What ECG changes you can get in stroke?
I think we are looking for any arrhythmia, like any AF or something, which can again contribute to like thrombi formation and again causing a secondary like thromboembolic stroke. And then
If a patient has a huge infarct, then because of increased ICP, patient can have cerebral T waves.
Cerebral T waves,
deep T waves, can be there.
bradycardia, cerebral T
Bradycardia,
waves, atrial fibrillation, supraventricular tachycardia. All these things can occur. So you have to look for all these things.
So this was apparently normal in this patient, and so we went to the secondary survey. So basically, this elderly female, 72-year-old, was actually having a history of sudden onset of symptoms 2 days back, but there was no any associated headache, vomiting, giddiness. There was no features of any seizures or any loss of consciousness. She didn't have any history of fever or any other complaints in the past 2 days. And she was taken to a nearby hospital where they took an MRI. It was showing an acute infarct in the right pons. So, for further management, they were referred to here for further evaluation. So, she is a non-diabetic, hypertensive, and dyslipidemia patient on medications. She doesn't have any non-allergic history. And before coming to hospital, her last meal was about 6 hours before coming to the hospital. So, on arrival, she is clinically stable. The only thing is this weakness is almost the same since past 2 days. It was not progressive or anything, but for further
Weakness is on which side?
on the left side.
Oh.
So now coming to the clinical examination. Clinically, her higher mental functions are okay. She's normal, conscious, oriented to the place, time, and everything. Her system-wise, her respiratory system already examined was normal. CVS is okay, and GIT and abdomen soft and non-tender. But coming to the CNS part, she had weakness on the left side, left upper limb and lower limb. She had 3/5 motor weakness, and also she had noticeable facial asymmetry, and which was showing weakness on the same side. So left side she had facial weakness along with left hemiparesis was noticed, but the weakness was more over the lower part of the left face, and because
But
of that,
normally it is not explained by your MRI finding. That is the only issue here.
yeah. Because MRI was more like a brainstem stroke,
Brainstem
and
stroke.
which we were expecting more like a contralateral lesion on the face, but here we are getting on the same side.
Same side.
So she didn't have any sensory loss or anything. She didn't have any pupillary issues or like any vision problems. She didn't have any persisting headache or any other complaints. And so this was a clinical examination. So in our hospital, actually, we took an MRI with an MRI angiogram was taken to assess the vessel status also. So it was again showing a normal circle of Willis middle and anterior and posterior cerebral arteries, and there was a focal stenosis of the V4 segment of right vertebral artery, and also the carotid artery, everything was found to be normal. So in the overall impression was there was areas of diffusion restrictions suggesting more of a acute infarct in the right hemipons area.
Okay.
And also there was a mild focal stenosis of the right vertebral artery, but other vessels were mostly normal. So this here we have mainly a patient with an acute hemipons infarct.
Any other investigations at this time? Appropriate investigation.
One thing is we checked her GRBs on arrival,
Okay.
and also her ECG was taken to rule out any arrhythmias. Adjuncts wise, it was mainly only those two were required, but during admission we sent for an entire panel of routine investigations was sent, like blood investigations, which we comprising of mainly complete blood count, then renal and liver functions were tested, and also her bleeding parameters like INR, everything was tested. And also, she was not on previously on ecosprin or anything, which we started after admission.
Okay.
So she was started on ecosprin 150 OD was started, and clopidogrel was also started, and a statin of 40 milligram atorvastatin was started.
Okay.
So from our management part, this were the basic medications we started, and she was already on antihypertensives. And on arrival, her BP was only 170/80, which didn't require any acute intervention at that stage. So she was admitted for observation. She was put on
So
continuous.
normally you have to start aspirin and clopidogrel. Loading dose has to be given. Whether it is myocardial infarction or stroke, loading dose has to be given.
Which we usually give 300, 380. This was
blood
already given from
glucose?
the.
Did you check it?
Check, sir.
Okay, that's important, essential.
It was
Why
one.
it is important?
Thing is actually hypoglycemia can sometimes present like
Hypoglycemia. Okay.
can present with features like stroke and
And hyperglycemia has got any role?
It triggers.
It will also worsen. Okay.
hyperglycemia can be a contributing factor to stroke.
Yeah. So there is
Hypercoagulable state. Hyperglycemia is hypercoagulable state. Hypoglycemia mimics stroke. Both are important.
and then echo. Echo is also another bedside important test to rule out any other
Any clot in the
thrombus in the heart walls. Okay.
So basically, the loading dose was given from the another hospital on before coming to here itself. So our hospital we started on continuous management. So ecosprin, clopidogrel, and aspirin was started, and post admission after entire routine blood test we sent for an MRI. Along with that, like cardiac evaluation, we sent took an ECG and echo was already done. It was not showing any mural thrombi or any other issues in the echo. She had a good LV function with ejection fraction of 60%, and so it was the basic findings. Post admission also she didn't have any issues, and there was no worsening of any clinical features.
You have to take a cholesterol level also. All myocardial infarction, stroke, you have to take a stat cholesterol level, because we are starting high dose of statin immediately after a stroke or myocardial infarction. So you may miss the diagnosis. So initially itself you take the cholesterol level. Only problem with cholesterol level is after a food, if you are taking cholesterol
Will be
level,
high.
triglycerides can be slightly higher. Other cholesterols will not be much affected by food. Okay, so you can take a stat cholesterol and see what is happening to the cholesterol. Suppose it is very high, then you can attribute the stroke towards your cholesterol. So she has to continue it lifelong.
This patient actually her samples were taken on arrival itself, but at that time she had an NP of about 6 hours, so really it was reliable value was there. So with these values we admitted the patient, and during admission we put her on continuous cardiac monitoring, and also her BP everything was maintained. So our idea was to like maintain a hemodynamic state, more like a physiological state itself, and also to continue the conservative management.
Why you want to continuously monitor this patient? Cardiac monitoring is required.
One thing is we want to rule out. One thing is actually any attributing factors of any arrhythmia which may have caused this.
That is correct.
Posterior circulation stroke, there will be no place for the edema to form. So any increase or edema can cause herniation, which will depict as Cushing's reflex of the patient.
So that is very important. Any patient who is in ICU who is developing a bradycardia, especially posterior circulation stroke, that is more important than it is important to know that whether arrhythmia is there. But at present there is no arrhythmia. But you have to instruct the nurse to look for the Bradycardia, because bradycardia is more dangerous in strokes, especially in the posterior circulation.
I think is mainly whenever, whenever there is an increase in cerebral edema, there won't be any like space to expand. It can actually cause this herniation.
So what is the difference between 80-year-old geriatric patient and the other normal adults regarding the cerebral edema?
One thing is actually geriatric people, they have an atrophied brain. So actually inside the cranial cavity, they will be having some more space than an like a young patient. Like,
Advantage.
The main inference, any other thing, importance?
inference, two things. One is an advantage because actually they have some more space to expand. Second thing, we will be noticing the signs only late.
Not only that, the hemorrhagic, subtle hematoma, that see little hemorrhage in adults and all immediately cause some focal symptoms. So this is a large space. So the symptoms free for prolonged period. We will not immediately able to come to a conclusion.
So this patient actually mainly we started on conservative management and is also currently ongoing treatment. But suppose this patient actually came in like an initial window period phase, we could have actually thrombolize this patient. So suppose the
What is the window period? Golden hours.
Golden hours. Preferable is actually less than 3 hours, but up to 44.5 hours we can opt for thrombolysis. So the drug of choice will be drugs like Arterial can be given, which will give us a dose of 0.9 milligram per kilogram can be opted for. And that the 10% will be given as an bolus over the first 1 minute, and the remaining will be given over 60 minutes.
During that first bolus dose, what all things you have to see in this patient?
One thing is actually like any drug, it can cause like anaphylactic reaction or something which you have to monitor.
Hypotension, anaphylaxis, rashes, all these things you can see first that bolus itself. It is developing reaction, then better to stop the drug and wait for some time.
Then even after starting the this thing treatment also we infusion also we have to continuously monitor the hemodynamics and also GCS, because there is a possibility that it can cause like a new onset bleed can happen during the infusion. And also for the next 24 hours there should not be any arterial pricks or anything that can cause an injury to the vessels, because anywhere we prick it can cause bleeding. So this kind of patients, if the sensorium is low, we put an RT tube and all even before starting the procedure itself.
So Riles tube, catheterization, all should be done before thrombolizing. That is very important. If you try to put a catheter after thrombolizing, there will be bleeding.
So after sitting this thing, and also if the patient is actually coming with a high BP, we have to reduce it before starting thrombolysis. So our target will be at least to like keep the
both high BP and low BP are important for thrombolysis. Both in myocardial infarction and stroke, it is same.
So preferably actually we keep the systolic BP less than 180 for thrombolysis, and also we keep the range like between like 140 to 180 it will be optimum for thrombolysis, because again low BP can again reduce the cerebral perfusion, and high BP can again actually hamper, especially if there's a bleed or anything. And again contraindication, if the patient is having had any recent surgeries in the recent past or something, we have to like think twice before giving thrombolysis. And also any recent acute MI or in the past 3 months or any major surgery in the past 2 weeks or something, we can think about like avoiding this thing. So we have to always think about the pros and cons of thrombolysis. So any patient coming to ED, actually there are simple things actually we can assess the possibility of stroke. One is a Cincinnati pre-hospital scale that is actually having 3 components only: facial droop, arm lift, and abdominal speech. In that, if anything is positive, there is a more than 70% chance of stroke, and if there is more than 3 positive, it is more than 85% chance of stroke. It's like a very easy to like identify this thing. And also there is something called the Rosier scale, which can be used as a recognition of stroke and also to differentiate between pseudo stroke. So there are some components like there is a history of any LOC or syncope, or there is any seizure activity, or there is acute onset of facial asymmetry, arm or leg weakness, or any speech disturbance or any visual defect. So anything we get a score between -2 to 5, and anything more than 0 is actually a likelihood of stroke. So anything less than 0 is actually, we cannot completely exclude stroke, but it could be more of a pseudo stroke. So these are some things actually we can do in emergency room to initially identify stroke. And also like any patient coming to acutely to emergency room, we do the Nihs scoring. The scoring system basically we can gives an idea whether the patient is having a mild, moderate or severe stroke, and whether they are a good candidate for thrombolysis or even mechanical thrombectomy. So we have like 11 components in the NHS score system, and anything less than 5 will be coming in the mild category, 5 to 9 will be moderate, and anything 10 and above will be in the severe category. And also the patient, even if they're coming in a late stage but with significant symptoms and with ongoing progression of symptoms, we can even think about late thrombectomy or late this thing also, like RTP also can be given in the late stages also if the patient's clinical symptoms are rapidly progressing. Some studies have shown benefit even beyond the winter period, starting on this thing RTPA in acutely progressive stroke is beneficial. And within 24, preferably within 24 or even maximum within 48 hours, if the patient is having significant weakness, we can go for mechanical thrombectomy. After assessing the vessel status and after assessing the total patient status, we can go for mechanical thrombectomy, considering if it is actually beneficial in the overall status. So that is one thing we can go for in the late stages of stroke. So this patient,
What is the recommendation on mean arterial pressure in stroke?
Mean arterial pressure, actually, the newer guidelines are not recommending to completely drop the BP to any normal range or anything. But preferably, we try to, if the patient is having a high BP like above 200 or something, we try to bring it down about 15 to 20% in the initial stage in the ED itself. So we can give drugs like labetalol or something, and we can bring down the BP to like about 15% to keep it around 180, 185 like that. So anything above 220 systolic or anything above 120 diastolic, we intervene. Otherwise, actually, we can keep it like that. But suppose we are planning for thrombolizing the patient, we have to bring it to a goal of below 180. So anything above 220, we have to intervene with antihypertensive to bring it about 15 to 20% from the target, the initial range. And
What is the ideal drug to be used there?
Preferably we go for IV agents like labetalol can be given.
If labetalol is contraindicated,
NTG can also be
NTG can be used. Hydralazine is a good drug, hydralazine. But now we don't get IV hydralazine
IV
here.
is not easily
But if it is available, that's a good drug.
Also, clinically, one interesting thing is actually this patient is having weakness on the same side. That is basically coming to the pyramidal and extrapyramidal tract. Basically,
Both facial nerve palsy and pyramidal tract lesion on the same side. That is the only problem here that cannot be explained by routine learning. That's all.
if you're clinically assessing the patient, you're suspecting more like a lower motor neuron lesion because actually it's on the same side. But because of we had an early imaging done, we got the nerve is actually a hemipons infarct.
Okay.
So the thing is actually pyramidal tract and extrapyramidal both are basically nerves coming from the brain to the spinal cord to the endpoints in the body to it's more like controlling the muscles all over the body. So the pyramidal is actually mainly for voluntary muscle control. Extrapyramidal is for involuntary muscle control. And pyramidal we have again two tracks, that is corticospinal and corticobulbar. Corticospinal will be going from the brain through the spinal cord to all endpoints in the body, and corticobulbar will be actually staying coming from the brain to the midbrain and in the brainstem, and again it's staying there only, but innervating all the muscles of facial muscles and everything. But thing is actually corticospinal tract again about 80% cross over to the opposite side and then goes down and innervate the end organs, and about 20% will be going straight without crossing over and supplying the end organs. So usually the most of the patients we are seeing actually the brainstem stroke will be affecting this 80% crossing over part opposite side. So we will be getting the ipsilateral limb weakness and contralateral facial weakness in most of the brainstem cases. But in a rare or a small subgroup of about 15 to 20% people, the infarct will be affecting that 20% of this directly ascending tract. And in this kind of patients, we will be seeing both on the same side.
Is facial
palsy and the limb weakness will be on the same side. So clinically, if you are trying to assess the patient, there can be we can make some confusion because we will be thinking it more like a lower motor neuron lesion. But centers where we have an early assessment imaging or something, it is actually easily differentiatable. But any patient in a emergency case, if you're getting an acute stroke, our main imaging will be modality.
So here, whatever it is, here main problem we face is this is a posterior circulation stroke. The same type of small stroke in anterior circulation, it is not a big problem. We can shift the patient to ward. But here, these type of patients we have to keep in a ICU where we can continuously monitor the raised ICP or whatever it is.
Okay. And also, like, suppose the patient had came to a hospital in the initial stages, so we will be going more in favor of a CT only. Initial plan will be CT. Except if you're like able to like get an MRI within 30 minutes or something, we go for an MRI. Otherwise, we preferably go for a CT. And if CT is normal, we would have gone for thrombolysis.
Why CT is preferred over MRI in acute stroke?
One thing is actually our priority is to rule out any bleed.
That is main reason. CT picks up bleed better than MRI in acute condition.
Second is actually if the patient is not compatible.
Less time.
Time is, if CT is very fast, MRI is slightly slower than CT. Third one, minimal movements.
Minimal movements.
Most of these patients may not lie down properly, so minimal movements can be okay for CT, but it is not at all okay for MRI. That will produce a lot of artifacts in MRI. So because of all these factors, normally CT is advised, but if you have time, then MRI can be taken.
So this patient currently, she is actually undergoing observation in our AETCM itself, and she is recovering currently. So our further plan will be like to plan for like neuro rehabilitation, because she will require actually physiotherapy and all muscle strengthening exercise to like recover her muscle weakness and all that.
Speech therapy, she has to talk because facial nerve is involved.
So speech therapy, swallow therapy, dysphagia clinic all should be like given
You want to give heparin for this patient?
This patient, if she is actually prolongedly lying in bed for like long time, we have to
In
start.
bedridden, we have to give DVT prophylaxis, not for stroke. We have to give DVT prophylaxis.
So which we can, if we are like thrombolizing, we can start after 48 hours, or else we can initially, so we can start for this thing. And yeah. So
Anything else?
The temperature, does it play any role? Hypo or fever?
fever. So suppose the patient is actually having a history of fever, we could actually think about other DDs also.
So keep the patient temperature normal.
Normal tendency.
Okay, that is more essential. And the glucose level is also normal value. Neither hyper or hypo. And BP already you told. And SpO2 should be minimum 95%. Hypoxia should be avoided. Never transfuse any dextrose containing preparations. Or allow the patient hyperglycemia. Because ischemic area there will be ischemic anaerobic metabolism. Again, that area lactoacidosis will be there. Lactate will be produced, and that will also injure the brain cells. More brain damage will be. And then what is malignant middle cerebral artery syndrome? So the edematous portion will be very large. So this will be not only middle cerebral artery. This will compress the anterior and posterior cerebral artery also. So the damage will be there. Sometimes the ischemic may transform to the hemorrhagic also. So initially it is ischemic stroke. So maybe transformation may also be possible. This is the thing.
Okay. Anything else you want to add? Okay. Thank you.
Thanks.